I'd like to present about a study using a mesenchymal stem cells for liver transplantation. The background is this. As you know, we have a limitation of size in LDLT, and the graft size is smaller, the outcome is worse. And graft size bigger, the outcome is good. So the trend is that we take the bigger graft, like right lobe with middle hepatic vein. That's what we did from 2000 to 2003 or 4. But this again, you know, that increase the risk to the donor. And unfortunately, we met one death around 2001 or 2. There was a donor death. That's basically due to the liver quality. The patient is donor. Actually, the patient is shown to have NASH afterwards, and remnant liver size in the donor is, as a result, less than 25%. It's critical to this kind of diseased liver. So, in other words, I summarize like this. So, bigger the graft, the results of the recipient is better. The bigger the graft, the risk to the donor is bigger as well. So, it's kind of compromise. So, the purpose of this study is we like to use smaller graft for sake of donor safety, and if you use such kind of graft, we have to enhance liver regeneration with the aid of something. So here, with the aid of cell therapy. Here, I show the pilot study with animal model. Outline is like this. So first, I'll talk a bit about MSCs. We take the subcutaneous fat or bone marrow from animals and isolate MSCs. And that has capability to differentiate into bone or fat or cartilage. And it characterizes also the surface marker, CD29 positive and CD105 positive, CD31 neither 34 negative. And factors that MSC secret increase factors for hematopoiesis and for immunosuppression and what we want, hepatocyte growth. On top of the HGF, various other factors secreted. So one of our colleagues, Dr. Teratani, published a paper about CCL4 damaged liver will recover by the administration of MSCs. And a couple of trials, clinical trials, published already for Crohn's disease. And this is for the kidney transplant. And again, the last one is encouraging to us that European people used MSCs for the liver transplantation, but aiming for tolerance induction, not for enhancing liver regeneration. Our first study is using the animal hepatectomy model. By using liver ischemia model and with hepatectomy model like this, so we put the clamp in the portal vein, portal hepatis, and create ischemia reperfuge injury, and cut a remnant segment out, and put MSCs intraportally. And MSC stays in the liver for some period. And AST and ALT at the 24 hour out of transplant is improved with the administration of MSCs. Histology and tunnel stain showed the apoptosis was suppressed by administrating MSCs. And HE stain showed that with the MSC administration, the structure is well preserved. In terms of the liver regeneration, when we administer MSCs, the liver regenerates better. So in summary, rat model, MSC is shown to ameliorate ischemic reperfusion injury and enhance liver regeneration. And we did a similar thing to the pigs, and we put MSCs after ischemic reperfusion injury. But with the pig, we put the shunt tube to avoid congestion to the intestine. And AST and ALT is again suppressed without giving bad damage to the portal pressure, which we saw in the initial phase. But we use some solution which is called ET Kyoto solution. The aggregation of the cell is avoided. So in pig model again, MSC is shown to ameliorate ischemia reperfusion injury. And transplantation model. At this time, whole liver transplantation model. This model is not for LDLT. We preserve the liver for 24 hours. Well, this study is looking forward to improve the results after long preservation. I mean, longer transportation or the no heart beating donor. That's what we are imagining. Take the graft out from the Lewis rat and preserved for 24 hours in UW solution. And that's as already known to you. The hepatovic vein and portal vein and the bile duct is reconstructed. And with arterial reconstruction as well, with a sleeve technique. And MSC is transplanted via portal vein, and histology and the liver enzymes are checked 24 hours after. And with a different set of groups, the LUTs are left intact and followed with survival without sacrifice. The quality of the operation is good, and the time is less than 17 minutes, around 15 minutes. And this showed, well, just tendency. The AST and LT is, well, LT is significantly, statistically significant, but AST showed just tendency. It's better, they are better with the administration of MSCs. Histology showed without administering the MSCs, they showed some necrosis, but that area is less with the administration of MSCs. And immunohistochemistry showed DLK or OV6. That's a marker for the hepatocyte stem cells enhanced with the administration of MSCs. And when we see survival, 1 week survival is much better with the administration of MST, with a rat transplantation model with long preservation, say 24 hours. So portal transfusion of the MSCs ameliorates the injury of the liver graft after prolonged cold preservation. So, but what we need is such kind of effect of MSCs with the living liver transplant, because we and a couple of other centers experienced bad adverse effect in the donor. So I just showed what we're doing right now with a rat transplant model. Well, rat transplant model is, of course, well published, and even with a reduced size liver transplant model is published elsewhere before. But that graft is, say, 50% or 6% of the original liver, so the reduction rate is not so extent. So in a sense, it's a bit far from living-related liver transplant in the clinical setting. So in order to study small four-size syndrome, sublethal LDLT model is necessary. Well, based on the anatomy, precise understanding of the anatomy of the liver, well, we established how to cut down liver in the back table. So by understanding the hepatic vein tributaries. And even with we understand we have to cut the part of the IVC to get such kind of graft. I mean, previously reported reduced size liver transplant in rat is just ligate the root of hepatic lobe as a mass. And sometimes that might cause bleeding, and sometimes that leave the necrotic tissue in the graft, which will make us difficult to get a stable results. Sometimes the results kind of sways, differs. And by understanding the course of the running course of IVC and the position of hepatic IVC, we cut part of the liver together with a part of the IVC like this, and make plastic in the back table. And at the same time, of course, we add hepatic artery reconstruction to mimic the clinical setting. But this is not by simple anastomosis, just do the sleeve anastomosis. And that's a pilot results. Well, initially the result is dismal, but as we use UW solution, the result is acceptable. And now we are checking the effect of MSCs for the liver regeneration with this model. So, in conclusion, MSCs has a potential to improve ischemia reperfusion injury and the potential to enhance liver regeneration. That's a bit different what's published with MSCs. But the previous publication is mainly due to the immunomodulation, aiming tolerance induction. But what we want in the LDLT setting is different. And so far the study with the LDLT model is underway. Thank you.